Question 1. Given the circumstances of a patient who presents with signs of pericardial effusion, how might an advanced cardiac sonographer optimize the echocardiographic view to accurately assess the effusion size and impact on cardiac function? A. By increasing the depth of the scan to visualize the pericardial space more clearly. B. By utilizing a high-frequency transducer to enhance resolution in the pericardial area. C. By adjusting the focus to the mid-chamber of the heart to assess pericardial space. D. By using color Doppler to evaluate the flow of pericardial fluid. Answer. Correct answer. B. By utilizing a high-frequency transducer to enhance resolution in the pericardial area. Explanation. To optimize the visualization of pericardial effusion, a high-frequency transducer is preferred for its superior resolution at shallow depths, providing clearer images of the pericardium and fluid. This allows for more accurate assessment of the effusion size and its impact on cardiac function. The depth setting must be adjusted. Optimal visualization, but simply increasing the depth is not the primary adjustment for effusion assessment. Color Doppler is useful for evaluating hemodynamic flow, not for direct fluid assessment in this context. Question 2. Mr. Anderson, a 68-year-old male, undergoes a Doppler echocardiogram to evaluate aortic valve regurgitation. The spectral Doppler shows a high velocity in the regurgitant jet. Based on this finding, which of the following parameters is most critical for quantifying the severity of the regurgitation? A. The pressure half-time of the regurgitant jet. B. The end diastolic velocity of the regurgitant jet. C. The time duration of the regurgitant jet. D. The peak velocity of the regurgitant jet. Answer. Correct answer. D. The peak velocity of the regurgitant jet. Explanation. In assessing aortic valve regurgitation, the peak velocity of the regurgitant jet is a critical parameter. It provides valuable information regarding the severity of regurgitation, as higher velocities suggest greater regurgitant volume. While the pressure half-time and end diastolic velocity are also important, they are secondary in the direct quantification of regurgitant severity. The time duration of the jet helps with timing, but does not directly correlate with severity in this case. Question 3. In the context of a stress echocardiogram, which of the following factors most influences the accuracy of wall motion analysis during peak stress? A. The timing of the images taken during the stress phase. B. The patient's body mass index (BMI) and chest wall thickness. C. The resolution of the Doppler imaging modality. D. The age of the patient undergoing the stress test. Answer. Correct answer. A. The timing of the images taken during the stress phase. Explanation. Wall motion analysis during peak stress is highly dependent on the precise timing of the echocardiographic images, ensuring they are captured at the point of maximal myocardial stress. This allows for accurate assessment of ischemic changes. Factors like BMI or chest wall thickness may affect image quality but do not influence the core analysis as much as the image acquisition, especially in stress echocardiography. Question 4. Which of the following is the most critical consideration when performing transesophageal echocardiography? In a patient with a suspected atrial septal defect, as A. The patient's ability to tolerate the sedation required for the procedure. B. Ensuring the image quality is optimal by selecting the appropriate transducer frequency. C. Assessing the shunt direction using color Doppler imaging. D. The positioning of the patient's head during the procedure. Answer. Correct answer. C. Assessing the shunt direction using color Doppler imaging. Explanation. When performing T for suspected AST, the most critical consideration is accurately assessing the direction of the shunt using color Doppler. This helps to confirm the diagnosis and determine the functional significance of the defect. While sedation, transducer frequency, and patient positioning are important, they are secondary to the accurate assessment of the shunt, which impacts clinical decision-making regarding AST. Question 5. When evaluating left ventricular LV diastolic function, which echocardiographic measurement is most useful in identifying early signs of diastolic dysfunction in a patient with hypertension? A. The ratio obtained from Doppler of the mitral valve inflow. B. The measurement of the left ventricular end diastolic dimension (LVED). C. The peak velocity of the pulmonary venous flow. D. The time to peak velocity of the aortic valve opening. Answer. Correct answer: a D-air ratio obtained from Doppler of the mitral valve inflow. Explanation: the ratio early to late diastolic filling velocity obtained from Doppler of the mitral valve inflow is a key indicator of left ventricular diastolic function. A reduced D-air ratio suggests impaired early diastolic filling, a common finding in early stages of diastolic dysfunction, particularly in hypertensive patients. LVED provides information on chamber size, while pulmonary venous flow and aortic valve measurements are less sensitive to early diastolic dysfunction. Question 6. Dr. Smith is conducting a Doppler evaluation of a patient with suspected pulmonary hypertension. During the assessment, he notes an increased tricuspid regurgitation jet velocity. What additional echocardiographic evaluation should Dr. Smith perform next to estimate the pulmonary artery pressure? A. Measure the peak velocity of the mitral inflow. B. Perform a right ventricular outflow tract Doppler velocity measurement. C. Measure the size of the right atrium. D. Evaluate the left ventricular ejection fraction. Answer. Correct answer: B. Perform a right ventricular outflow tract Doppler velocity measurement. Explanation: to estimate pulmonary artery pressure (PAP), the right ventricular outflow tract Doppler velocity is measured. This measurement, in combination with the tricuspid regurgitation jet velocity, allows for the calculation of the estimated pulmonary artery pressure. The other options are unrelated to directly estimating PAP. LV function and right atrial size are important, but they do not replace the critical Doppler measurement needed in this case. Question 7. In contrast to traditional two-dimensional echocardiography, how does three-dimensional echocardiography (3D) enhance the assessment of complex valvular disease, such as mitral regurgitation? A. By providing a more accurate measurement of left atrial volume. B. By improving visualization of the mitral valve leaflets and the regurgitant jet in real time. C. By enabling the measurement of the heart's chamber diameters more accurately. D. By improving the sensitivity of detecting coronary artery disease. Answer. Correct answer: B. By improving visualization of the mitral valve leaflets and the regurgitant jet in real time. Explanation: three-dimensional echocardiography provides superior visualization of the mitral valve leaflets, regurgitant jets, and the overall anatomy, offering a more detailed and accurate representation of complex valvular pathology such as mitral regurgitation. This enhanced visualization is critical for treatment planning, decision-making. While 3D echocardiography can aid in assessing chamber volumes, its primary advantage lies in valvular and jet visualization. Question 8. Mr. Jackson is being assessed for a possible ischemic cardiomyopathy using echocardiography. During the examination, wall motion abnormalities are noted. Which of the following is the most reliable echocardiographic finding to distinguish ischemic from non-ischemic cardiomyopathy? A. Presence of left ventricular dilation. B. Hypokinesis or akinesis in specific myocardial regions. C. Thickened ventricular walls in the septal region. D. Mitral valve prolapse. Answer. Correct answer: B. Hypokinesis or akinesis in specific myocardial regions. Explanation: wall motion abnormalities such as hypokinesis or akinesis in specific myocardial regions are key indicators of ischemic cardiomyopathy, particularly when localized to areas supplied by a coronary artery. These findings are often not present in non-ischemic forms of cardiomyopathy, where the wall motion abnormalities tend to be diffuse. Left ventricular dilation is common in both types but is not as diagnostic as localized wall motion defects. Question 9. When evaluating right ventricular (RV) function using echocardiography, which of the following findings would most likely suggest pulmonary hypertension? A. Increased right atrial pressure. B. Reduced right ventricular systolic function. C. Dilation of the right ventricle. D. Tricuspid regurgitation jet velocity greater than 3.4 meters. Answer. Correct answer: D. Tricuspid regurgitation jet velocity greater than 3.4 meters. Explanation: a tricuspid regurgitation jet velocity greater than 3.4 meters is a hallmark of elevated right ventricular systolic pressure and is often seen in patients with pulmonary hypertension, while right atrial pressure, RV systolic function, and RV dilation. Consider RV strain, the tricuspid regurgitation velocity, a more direct and reliable indicator of pulmonary hypertension. Question 10. According to recent guidelines, what is the recommended role of contrast echocardiography in the diagnosis of left ventricular thrombus? A. It is used to assess the functional status of the left ventricle in patients with ischemic heart disease. B. It provides superior sensitivity for detecting thrombus in the left ventricle, particularly in patients with poor acoustic windows. C. It is only recommended in cases of severe mitral regurgitation. D. It should only be performed when other imaging modalities are unavailable. Answer. Correct answer. B. It provides superior sensitivity for detecting thrombus in the left ventricle, particularly in patients with poor acoustic windows. Explanation. Contrast echocardiography significantly enhances the sensitivity of detecting left ventricular thrombus, especially in patients with suboptimal imaging windows due to poor acoustic quality. This technique improves the visualization of thrombus by enhancing the endocardial border, making it to identify thrombi in the left ventricle, particularly in post-myocardial infarction patients or those with reduced ejection fraction. Question 11. In the context of a patient with long-standing hypertension and symptoms of fatigue and dyspnea, echocardiography reveals concentric left ventricular hypertrophy and a preserved ejection fraction. The Doppler analysis shows a high eta ratio and shortened deceleration time. What is the most likely interpretation of the diastolic function? A. Grade I diastolic dysfunction. B. Grade Omen systolic dysfunction. C. Grade Rome diastolic dysfunction. D. Normal diastolic function. Answer. Correct answer. C. Grade Rome diastolic dysfunction. Explanation. The combination of concentric ovation, a restrictive filling pattern, high a ratio shortened deceleration time is indicative of grade Rome diastolic dysfunction. According to ACS guidelines, this pattern suggests reduced compliance and elevated filling pressures. Grade I would show impaired relaxation, low E, and grade O mentoid pseudo-normalization. Restrictive physiology is crucial in patients with preserved F, as it often signals advanced diastolic disease. Question 12. From a historical standpoint, is Lopez, a 56-year-old woman with a bioprosthetic mitral valve, undergoes routine follow-up echocardiography. Color Doppler shows mild central regurgitation and continuous wave Doppler reveals a mean gradient of 7 mHg at rest. What is the most appropriate interpretation? A. Prosthetic valve dysfunction due to thrombosis. B. Normal function of bioprosthetic mitral valve. C. Severe mitral regurgitation. D. Evidence of structural valve deterioration. Answer. Correct answer. B. Normal function of bioprosthetic mitral valve. Explanation. A mean gradient 10 mHg and only mild central mysto are within the normal limits for a functioning bioprosthetic mitral valve. The ACS 2009 recommendations note mild central regurgitation is often seen and not pathological. There's no evidence of thrombosis, which would elevate gradients, or structural deterioration, which would eccentric or worsening mysto or abnormal leaflet motion. Question 13. The relationship between myocardial strain imaging and traditional LVEF assessment has gained attention in recent years. Why is longitudinal strain often considered a more sensitive indicator of early systolic dysfunction? A. Strain imaging is less dependent on image quality than LVEF. B. Longitudinal fibers are the last to be affected in disease processes. C. LVEF overestimates function in concentric hypertrophy. D. Global longitudinal strain reflects endocardial function, which is affected early in disease. Answer. Correct answer. D. Global longitudinal strain reflects endocardial function, which is affected early in disease. Explanation. GLS quantifies myocardial deformation, specifically tracking endocardial motion, which is often impaired before global LVEF decreases. This is especially relevant in conditions like hypertensive heart disease or chemotherapy-induced cardiotoxicity. According to ACS guidelines, a normal GLS is a negative 20%. LVEF may remain normal despite early myocardial damage, making strain-sensitive tool for early detection. Question 14. Given the circumstances of Istatanaka, who presents with fever and a new murmur, a transthoracic echocardiogram reveals a mobile echo density attached to the atrial side of the mitral valve leaflet. Blood cultures are positive for Staphylococcus aureus. What is the most likely diagnosis? A. Mycoma. B. Vegetation due to infective endocarditis. C. Papillary fibrillostoma. D. Thrombus. Answer. Correct answer. B. Vegetation due to infective endocarditis. Explanation. Mobile echo densities on the low-pressure side of valves e.g. atrial side of mitral in the context of positive cultures and systemic infection strongly suggest infective endocarditis. The modified Tuke criteria incorporate echocardiographic findings such as vegetations. Staph aureus is a common cause. Myxomas are typically found in the left atrium attached to the septum, and fibrillostomas are smaller and often attached to the aortic valve. Question 15. During the process of intraoperative T4, a patient undergoing mitral valve repair, the transgastric short axis view is used to assess left ventricular function. What is the most important feature of this view? A. It is ideal for evaluating the aortic valve morphology. B. It provides optimal visualization of apical thrombi. C. It allows real-time assessment of global and regional LV systolic function. D. It eliminates reverberation artifacts from the lungs. Answer. Correct answer. C. It allows real-time assessment of global and regional LV systolic function. Explanation. The transgastric short axis view provides a circular cross-section of the LV at the papillary muscle level, enabling real-time assessment of radial wall motion and regional function. It is commonly used intraoperatively to monitor surgical results. T guidelines from ISESCA highlight this view's utility in evaluating myocardial performance, especially during weaning from bypass. Question 16. To better understand the implications of contrast echocardiography, consider a patient with suboptimal endocardial definition on the EE. Which of the following best represents the role of contrast in this case? A. Detecting pericardial effusion. B. Differentiating thrombus from traculations. C. Evaluating myocardial perfusion directly. D. Visualizing the coronary arteries. Answer. Correct answer. B. Differentiating thrombus from traculations. Explanation. Contrast agents enhance endocardial border definition, aiding in the identification of apical thrombi versus normal structures like traculations. While some contrast agents can evaluate myocardial perfusion, that requires specific protocols and is not routinely done. Visualization of coronary arteries requires ET or MRI. As guidelines emphasize contrast use when two contiguous segments are poorly visualized. Question 17. Upon closer examination, istacolid, a 42-year-old man, is undergoing a stress echocardiogram. During peak stress, there is hypokinesis of the mid-interostal and anterior walls, which were normal at baseline. What does this suggest? A. Prior myocardial infarction. B. Hypertrophic cardiomyopathy. C. Stress-induced ischemia. D. Apical thrombus formation. Answer. Correct answer. C. Stress-induced ischemia. Explanation. Development of new regional wall motion abnormalities during stress indicates inducible ischemia in corresponding vascular territories. The mid-interostal and anterior walls are supplied by the LAD artery. Stress echocardiography guidelines from AS specify that such findings support a diagnosis of CAD. Prior MI would show baseline abnormality. Hypertrophic cardiomyopathy has different morphology and motion patterns. Question 18. While examining a patient with suspected constrictive pericarditis, the echocardiogram shows a septal bounce, exaggerated respiratory variation in transvalvular flows, and hepatic vein diastolic flow reversal with expiration. What does this pattern best support? A. Restrictive cardiomyopathy. B. Cardiac tamponade. C. Constrictive pericarditis. D. Severe tricuspid regurgitation. Answer. Correct answer. C. Constrictive pericarditis. Explanation. Classic signs of constrictive pericarditis include septal bounce, respiratory variation in mitral tricuspid inflow, and reversal of hepatic vein diastolic flow during expiration. These reflect ventricular interdependence due to the non-compliant pericardium. Restrictive cardiomyopathy lacks respiratory variation. Tamponade shows chamber collapse and blunted flow but not bounce. As guidelines on pericardial disease define these distinguishing features. Question 19. The most significant aspect of assessing pulmonary hypertension on echocardiography involves multiple parameters. Which of the following is most specific for elevated pulmonary artery pressures? A. Right atrial enlargement. B. Flattening of the interventricular septum during systole. C. Elevated jet velocity. D. Inferior vena cava dilatation. Answer. Correct answer, C. Elevated jet velocity. Explanation. The most direct and specific measure of pulmonary artery pressure is the peak tricuspid regurgitation velocity, from which systolic pulmonary artery pressure (SPAP) can be estimated using the Bernoulli equation. Septal flattening and rate changes are supportive but not specific. As guidelines on pulmonary hypertension emphasize the central role of Doppler-derived velocity in initial non-invasive assessment. Question 20. In comparison with other imaging modalities, what is the primary advantage of intracardiac echocardiography in guiding structural heart interventions? A. Low cost compared to MRI. B. Avoidance of radiation exposure. C. Real-time, high-resolution intracardiac imaging without general anesthesia. D. Superior evaluation of coronary arteries. Answer. Correct answer, C. Real-time, high-resolution intracardiac imaging without general anesthesia. Explanation. ICE provides detailed visualization of cardiac structures, particularly useful during catheter-based procedures like ASFO closure or transeptal puncture. Unlike T, ICE does not require general anesthesia and offers high-resolution imaging from within the heart. It is not used to evaluate coronary arteries. Guidelines from the Rhythm Society and AC recognize ICE as an effective tool in electrophysiology and structural procedures. Question 21. A 52-year-old male with a history of alcohol use disorder presents with symptoms of heart failure. Echocardiography reveals global hypokinesis, a dilated left ventricle, and a reduced ejection fraction of 25%. Which additional echocardiographic finding would best support a diagnosis of dilated cardiomyopathy? A. Asymmetric septal hypertrophy. B. Reduced mitral annular systolic velocity. C. Preserved global longitudinal strain. D. Hyperdynamic right ventricular function. Answer. Correct answer, B. Reduced mitral annular systolic velocity. Explanation. In dilated cardiomyopathy, reduced systolic function includes impaired longitudinal contraction, often seen as reduced S velocity on tissue Doppler imaging. AS guidelines support using S as a surrogate for systolic function, especially in cases with reduced F. The other options are more consistent with HCM or hyperdynamic states and not ESM. Question 22. During intraoperative T after mitral valve replacement, color Doppler reveals a paravalvular leak with a high-velocity jet located adjacent to the anterior mitral annulus. Which of the following best describes the potential consequence of an untreated significant paravalvular leak? A. Thrombus formation on the atrial septum. B. Chronic anemia due to hemolysis. C. Elevated pulmonary capillary wedge pressure. D. Increased right ventricular systolic pressure. Answer. Correct answer, B. Chronic anemia due to hemolysis. Explanation. Paravalvular leaks can cause hemolytic anemia due to shear stress on red blood cells passing through high-velocity jets. ASN-esque valve guidelines emphasize identifying and quantify PVLS, especially in symptomatic patients with anemia, heart failure, or risk of endocarditis. Question 23. A 34-year-old female with systemic lupus erythematosus is found to have thickened aortic valve leaflets with irregular echogenic masses. She has no fever and blood cultures are negative. What is the most likely diagnosis? A. Liebman-Sachs endocarditis. B. Infective endocarditis. C. Rheumatic valve disease. D. Fibroblastima. Answer. Correct answer, A. Liebman-Sachs endocarditis. Explanation. Liebman-Sachs endocarditis is a non-bacterial thrombotic endocarditis commonly associated with sleep. It typically involves the mitral or aortic valves and appears as sterile vegetations. The absence of fever and negative blood cultures help differentiate from infective endocarditis. Question 24. A patient with atrial fibrillation is referred for transesophageal echocardiography prior to cardioversion. Which view is most optimal for detecting left atrial appendage thrombus? A. Midesophageal long axis view. B. Deep transgastric view. C. Midesophageal two-chamber view. D. Midesophageal love view at 9 Tydeg 11-0 DE G. Answer. Correct answer. D. Midesophageal love view at 9 Tydeg 11-0 DE G. Explanation. The midesophageal view between 9 Tydeg and 110 Deg is optimal for visualizing the LA. It allows clear visualization of potential thrombi. The AST guidelines recommend this angle range specifically for evaluating the LA prior to cardioversion or LA closure procedures. Question 25. During contrast-enhanced echocardiography in a patient with apical cardiomyopathy, a dense echogenic mass is visualized in the apex. After contrast administration, the mass remains unopacified. What is the most likely diagnosis? A. Papillary muscle hypertrophy. B. Apical thrombus. C. Moderator band artifact. D. Ventricular diverticulum. Answer. Correct answer. B. Apical thrombus explanation. Lack of contrast ossification in a defined region suggests the presence of a thrombus. This is especially common in apical cardiomyopathy where blood stasis increases thrombus risk, as contrast echocardiography guidelines highlight this as a primary indication for contrast use. Question 26. A patient with known pulmonary hypertension has flattening of the interventricular septum throughout the cardiac cycle and a dilated right ventricle. What echocardiographic parameter best quantifies right ventricular pressure overload? A. Ratio. B. TAPS. The area V diameter ratio. D. Peak gradient. Answer. Correct answer. D. Peak gradient explanation. The peak gradient provides an estimate of systolic pulmonary artery pressure, making it the best quantitative indicator of RV pressure overload, as pulmonary hypertension guidelines consider this a critical metric in pH assessment. TAPS assess RV systolic function, not pressure. Question 27. A young athlete undergoes echocardiographic screening. He has symmetric LV wall thickening, normal diastolic filling patterns, and no symptoms. His global longitudinal strain is negative 19%. What is the most likely diagnosis? A. Hypertrophic cardiomyopathy. B. Physiologic athlete's heart. C. Amyloidosis. D. Dilated cardiomyopathy. Answer. Correct answer. B. Physiologic athlete's heart explanation. Symmetric hypertrophy with preserved or near normal GLS and normal diastolic filling in an asymptomatic athlete favors physiological remodeling. HCM often has asymmetric hypertrophy and impaired strain, as sports echo guidelines help differentiate athletes' heart from pathological hypertrophy. Question 20. A 70-year-old man presents with severe aortic stenosis. Echocardiography reveals a stroke volume index 35 mmM, mean gradient of 38 G, and an AVA of 0.7 cm. How should this be classified? A. Moderate as with preserved F. B. Low flow, low gradient as with preserved F, paradoxical. C. High gradient severe as D. Pseudo-severe as. Answer. Correct answer. B. Low flow, low gradient as with preserved F, paradoxical. Explanation. This case meets criteria for paradoxical low flow, low gradient severe as low stroke volume, low gradient, but small AVA and preserved F. The ACS guidelines emphasize assessing stroke volume index to identify the specific phenotype. Question 29. A patient with hypertrophic obstructive cardiomyopathy undergoes Valsalva maneuver during echocardiography. What effect is most likely observed? A. Decreased LVOT gradient. B. No change in LVOT obstruction. C. Increased LVOT gradient. D. Decreased septal thickness. Answer. Correct answer. C. Increased LVOT gradient. Explanation. Valsalva decreases preload, narrowing the LVOT and increasing the dynamic obstruction and gradient. This maneuver is commonly used to provoke latent obstruction in HOCM patients, as guidelines on HCM stress the importance of provocative maneuvers for accurate gradient assessment. Question 30. A post-MI patient develops acute hypotension. Echocardiography reveals right ventricular enlargement, septal flattening, and a D-shaped left ventricle, which diagnosis is most consistent. A left ventricular free wall rupture. B. Acute mitral regurgitation. C. Right ventricular infarction. D. Takotsubo cardiomyopathy. Answer. Correct answer. C. Right ventricular infarction. Explanation. RV infarction leads to RV dilation, impaired contractility, and septal shift, D-shape, due to increased RV pressures. It is a common cause of hypotension post-MI and should be suspected when inferior MI is present. Septal flattening is a key echocardiographic sign.